not visible to the naked eye, the anterior portion, because that bony part that's protruding outwards. So that's that wax plug. You can see the top one, I think that was from the ears. So sometimes we just have to take the patient's word. But it was really impacted. This is the indentation here. You can see that circular crater created by something pushing into it. Now, around the periphery of this wax plug, you've got a thick layer of skin that's semi-shedded, I would say. So part of it's still attached to the ear canal. It's very adhesive, sticky. The oil, I've just been still helps with that. It kind of almost helps to break down that adhesiveness. And I'm just trying to separate this plug around the edge of the canal wall first. Now, the patient was a lovely gentleman, but they did, and I take it as a compliment actually, because they felt really comfortable, but they were chattering quite a lot during the procedure. In some people's ears, it doesn't affect the procedure, you just can't see the canal move, but in this case, as they were talking, when you open and close your jaw, it actually flexes some muscles, the jaw, and the cartilage portion of the ear canal in particular, so the outer third, it can come up and down. And it did make it sometimes a bit difficult before the procedure, so I had to, in a very kind and polite way, just ask the patient if they can just remain still between certain parts. And we had a good talk after the procedure about various things, and which was great. So a very interesting patient. Had a lot of stories, which was fantastic, and yeah, a very interesting individual. So I've got probably the outer quarter out. We're now, I would say, on the bony part of the ear canal. So that previous wax was in the cartilage now. We're working on the bony part. We've just gone past the second bend. That's a good landmark indicator to advise and separate the first and second bend. Sorry, there's a good boundary to separate the cartilage portion of the ear canal and the bony part. So anything towards me before that second bend is likely to be cartilage, and anything beyond that second bend is likely to be the bony part of the ear canal. So the ear canal is divided into three, so the outer third cartilage, the inner 2/3 bone. Sometimes you can also tell by the colour of the canal wall, and I don't know if you can see there, just underneath the plug, the ear canal is a bit more red, pink, whereas the closer to the tip of the endoscope, it's more pale. So because the skin that lines the cartilage is a lot thicker, in comparison to the skin that lines the bony part of the ear canal, the blood vessels are more visible in the inner 2/3 of the ear canal because they're near the surface a lot more in comparison to the cartilage portion. So we've got blood vessels, blood pumping through, it's going to give that more pinky red appearance. So I'm just trying to manipulate this plug, and I'm trying to navigate the bends and twists in the ear canal, and it's almost out of the ear now. It's quite a sizable tooth. If you wait to the end of the video, you'll see these images. You can see probably 2/3 of the eardrum, the posterior 2/3, but in the anterior canal wall, so the front part of the ear, you've got the sticky bit of wax. I'm just using the fine end. I just want to avoid the bony part. Now you'll see more so in their right ear, but the anterior canal wall is slightly protruded, so it comes to the more midline. I saw that on the screen there. Just a little speck of wax, I'll just vacuum over it. Here we can apply a bit of pressure to the cartilage. It's not uncomfortable for the patient. If we were doing this on the bony part, then well, we wouldn't be able to do that because it would just be too uncomfortable for the patient, and they'll be screaming at the top of their voice. So this is their right ear. Although this ear, the patient felt wasn't as bad as the left ear. In terms of removal, it's a bit more tricky. So they've been using some drops here at the surface. I asked them which drops, I wasn't sure, but I suspect it's hydrogen peroxide, and you can always tell when someone's used hydrogen peroxide drops. It turns the wax very mushy and glutinous. It's like a mashed potato consistency. Sorry to anyone who's having mashed move. So I've just put some olive spray in here, just to help the wax together, change the consistency. Just lens, stain all the wet wax that's in the ear. There's a few hairs here matted. So I'm just trying to work at the posterior canal wall, the back section, trying to lift this away. You can see more of the ear canal, so I'm not sure exactly where the ear canal is posteriorly. I can see the ear canal to the right, anteriorly, but posteriorly I just want to reveal some of the ear canal, so I've then got an idea of my boundaries. When you can't see the ear canal and you're using an instrument, you're always back in your mind maybe wary whether you make contact with the canal wall, so if you bend these not too much into the wax. So I would like to do some ear canal around the edge, and it just helps me to plan the rest of the procedure. So I think this is where the patient started talking a bit more here, so I just had to, at that point, came out and just explain that when they were talking, their jaws moving. Quite often I'm having conversations with patients. Sometimes I think, why am I? Because I'm not sure they can hear me with the suction probe in. But some patients' jaw it doesn't affect their ear, but with this particular patient, it's making a big difference. Slowly loosening that. Now I can see, as I said, all the way on the edge, I can see the ear canal. This is why an endoscope is so brilliant, the field of view that it provides. And I personally feel that there's no better method of viewing the inside of the ear when performing earwax removal than an endoscope. I've got an operating into microscope at my clinic. In fact, I've got several, and I've used head magnifying loops. I feel quite limited in terms of magnification, depth of view. With an ENT microscope, when I use that, yes, the magnification is great, but one of the things that people often say that ENT microscope that gives you binocular vision, and binocular vision is seeing an object with both eyes independently, and your brain can then merge the two images and it gives you depth perception. With an endoscope, there is 3D endoscope, so you view it on a monitor and you wear 3D glasses, but essentially what we're doing here is viewing it on the screen of, I'm using the iPhone SE actually, the 2022 version, the 3rd generation. Because you're viewing it off a flat screen, you're not able to use binocular vision. So if I had one eye closed, I'm going to get the same view compared to having both eyes open. But with an ENT microscope, if you just view with one eye, you're not going to get that depth perception. But if you've got a very narrow ear canal and the wax is very deep, you still, I don't think you always get that binocular depth perception with an ENT microscope, if truth be told, because what an ENT microscope tries to do, it artificially converges your interpupillary distance. So in order to see an object in the ear canal with both eyes independently, your eyes must be very close together, and it's not possible because of the diameter of the ear canal, about a centimetre in height, and the width about 0.7. So a microscope artificially, it's like a periscope in a submarine, it converges your eyes closer than they really are. So it's artificially bringing them together, but not that they're overlapping, which can then enable you to see wax very deep in the ear with both eyes independently. But if you've got a very, very narrow ear and wax very, very deep, you're still not going to be able to converge your interpupillary distance enough to take advantage of the binocular vision. Now, with an endoscope, I still get depth perception. Lots of surgeons do, hence why they do endoscopic ear surgery. You just rely on different cues, and one of the cues that I rely on for depth perception with an endoscope is the field of view. When you can see the whole ear canal and the landmarks and the shadows, and then you move the endoscope deeper in the ear and you can see the object in front of you magnifying. You look at the rate of speed of change when you're going towards an object, and you're looking at that and the speed of the ear canal on the side, you call that motion parallax. It provides you with depth perception. As you touch the ear wax, you get that sensation. So I actually feel I get better depth perception with an endoscope as opposed to an ENT microscope, but I suppose also that is in part because I'm using an endoscope all the time and my brain is wired up to use an endoscope. So with an ENT microscope you just wouldn't get the same view. You'll see a quarter of the ear canal, but it'll be very magnified. And the Waxscope works, so the Waxscope is the other product that I'm soon to be launching. It works on the same principle, more or less, of an ENT microscope. The view is very magnified and narrowed. Again, you don't necessarily say you get binocular vision, the defined version of binocular vision or depth perception, I would say, with the Waxscope, because again, you're looking on a 2D screen. But the Waxscope is more user-friendly to use than an endoscope. With an endoscope, I didn't realise how difficult it would be to train and for others to acquire that skill. It is a very difficult skill, and I appreciate that a bit more now. And train people to use it, and that's because you need a lot of bilateral integration. You're having to use both hands simultaneously, as well as your eyes, because you're having to use the endoscope right now. You can't see it because you're inside the ear, but the left-hand side tip of the endoscope is being used to stretch the ear canal open and wide open and straighten the ear canal, and also to visualise the wax simultaneously, and then using my right hand with the instrument. So you constantly have to make little fine motor movements with both hands, and they have to be in synchrony. And if not, it's a very difficult procedure to learn. So the Waxscope, like an ENT microscope, it has a speculum, which is a black plastic funnel, which is hollow. It's wide at one end, narrow, tapers at the other end, and the taper then goes into the ear, and you can use the speculum instead to straighten the ear canal and widen it. But that inhibits some of the view, but it's still very, very good. If you visit the link on the description, if you're watching the raw format, you can visit the ClearWax YouTube channel where I've uploaded about 100 more, the next 100 videos of the Waxscope. I haven't in a while, I was just waiting for the launch now because it's imminent. But yeah, an endoscope, just the view it provides, it's unparalleled. So I'm just mopping up near the entrance. On this side, the anterior canal wall is even more prominent, and the wax plug is lodged behind that, so you can see this side is a bit more tricky. But we got there in the end. Stretch the ear open, trying to do the whole ear. So part of that eardrum is not visible to the naked eye, the anterior portion, because that bony part that's protruding outwards. So that's that wax plug. You can see the top one. I think that